and its management in deep. And we were concentrating mainly on Harrison last time in our class. Now we'll go a step ahead and see what's there new in Parkinson's disease and about the hyperkinetic movement disorders. That is regarding all the hyperkinetic movement disorders like dystonia, chorea, uh, tics, tremors, etc., etc., which also includes the special diseases like Huntington's disease, Wilson's disease, etc., will be dealt in another sessions as hyperkinetic movement disorders, which will be done by Dr. Ashish, who is also a neurologist, which will be done in the last week of February in 2 sessions. So I think it will be a much more interesting one because he specializes in uh, movement disorders. And in the March month, as per the requests, multiple requests during the March month, we are planning to mainly concentrate on pediatric neurology. So pediatric neurology was not touched upon very well last time because, and as you know, last time NEET mainly had a large bulk of questions from pediatric neurology. And this time we don't want to be behind in studying pediatric neurology. So we'll brush upon pediatric neurology and emphasize on pediatric neurology a bit ahead. So March month, I think we'll spend more on pediatric neurology. First week will be we'll be having second part of hyperkinetic movement disorders, but next rest of the month we'll try to finish pediatric neurology part because the aims first session would be coming by maybe April May month, and so that's why we'll finish pediatric neurology. So till now we have completed stroke 2 sessions, dementia 2 sessions, and with this we will be completing hypokinetic movement disorders 2 sessions. Next week I think we'll take a leave, and the week after that we will be dealing with one class of neuromuscular junction disorders. After that only we will be starting with hyperkinetic movement disorders. So I think it's already time. That is 8:30. I had good response about the last class because it was a bit confusing and not that touched about topic that is about the pathophysiology, very confusing basal ganglia circuitry. Most of them had told that it was very useful. The circuitry was very useful. Hope you had all had gone through the circuitry again in Harrison or whatever which was shown in the class and in the videos, because while hearing all the circuitry we may think that it's very easy. Once you easy way of learning is you study it and teach it to someone so that you have it in your mind, especially for solving the questions. So we'll start from where we left last time. So I think we'll start the topic today's class. So I think about 42 have joined. I expected more, but I think we'll not waste time. We'll start the class. So we'll start from where we have left. It's just a revision of the last class. We'll emphasize on the topics which needs to be given more importance, especially in the point of view that is especially on emphasizing on the Bradley chapters, Bradley portion. So what we left was that habits are dopamine driven feedback loop, and when dopamine rises, so does our motivation to act. So as I am emphasizing and telling you again and again, exams may be in July or August, or maybe delayed due to some reason, or maybe early, or whatever happens. Make it a habit to learn. So as we all know, if you are following this fine Neurophilia series, you are learning at least something every week, or some portion at least every Wednesday, because before coming to class you are learning something. You are reading Harrison or trying, or after every 2 classes you are trying to answer the questions and do the exams. So you are learning something. So it is also dopamine driven. So make a habit, increase the dopamine in your basal ganglia circuitry. So let's start the first question. So let's start the polling first. So today's poll, sorry. So today's poll question, first question would be, okay, first question, you can see the questions, right? Yes, all are answering it correctly. Uh, so what is the neurotransmitter which is involved in the basal ganglia circuitry? We had seen the direct and indirect pathway in the circuitry. So what is the pathway between the cerebral cortex and the subthalamic nucleus? So what we are talking about is what actually we studied regarding the direct pathway, the indirect pathway, and a new one which we came to our notice was the hyperdirect pathway. So what we are dealing with now is the hyperdirect pathway, which we know that is excitatory, and we know that the excitatory neurotransmitter in the brain is actually glutamate. And so the answer here is actually glutamate. So just revising the last topic. So we had studied last time that the cortex to striatum with disinhibition to thalamus, leading to a positive feedback. This forms the direct pathway of the normal circuitry of basal ganglia, and from striatum to globus pallidus externa to subthalamic nucleus to interna forms the indirect pathway, which is inhibitory to thalamus. And the substantia nigra acts as the policeman through the dopamine pathway, that is the D1 receptor as well as the D2 receptors. And there is a balance, fine balance occurring between these two with the help of dopamine in the substantia nigra. And this helps in the smooth movement of a normal person. So what happens is actually there is a direct pathway, indirect pathway, and what we were talking in this question was another pathway, that is a hyperdirect pathway, which connects the cortex to the subthalamic nucleus, which is excitatory. So all this is which is given in blue is actually excitatory, and the neurotransmitter involved mainly is glutamate, and all which is shown in red arrows are inhibitory and has GABA as the neurotransmitter. And the black ones are the dopamine, which has varied action. D1, there are 5 dopamine receptors, D1 to D5. And in brain, basically D1 and D2 are the type of receptors which has facilitatory as well as inhibitory action. So that is what was discussed last time. So that was regarding direct, indirect, and the hyperdirect pathway. So second question, what is the neurotransmitter involved in the pathway in the basal ganglia circuitry? Now we are talking about subthalamic nucleus and the substantia nigra pars reticulata, SNR. So we are talking regarding SNR and subthalamic nucleus. So try to read the question again and answer. So you can see the question. So we are talking about the neurotransmitter between subthalamic nucleus and SNR. I purposefully tried to confuse you. So acetylcholine doesn't come in the picture as such. So some people are trying to answer this acetylcholine. So that doesn't. So I have told you, just think of the blue arrow, red arrow, and the black arrows. So dopamine is not given in the option. So it could be either glutamate or GABA. So what do you think it is? So we are talking about a connection between the subthalamic nucleus and the SNR. We last time discussed that even though substantia nigra pars reticulata is present in the midbrain, it is homologous to actually globus pallidus interna. So the answer here is actually, we'll discuss it. So what we are talking, again, the same pathway, direct pathway. We are now dealing with what is called the indirect pathway. So we are talking about this subthalamic nucleus to the homolog, that is globus pallidus into SNR is in homologous to GPI. So we are talking regarding this connection, that is subthalamic nucleus and GPI. So this is actually excitatory. So here also the same answer comes, that is glutamate. So don't get confused when such a question comes. Just make yourself comfortable with this pathway. So read, try to write it down, read again and again regarding this pathway. So now you will be knowing that the neurotransmitter involved is actually excitatory, and it's again glutamate is the answer. So this is actually a bit confusing. This is taken from the table in Bradley. So you have to know that apart from the usual questions in Harrison, extra questions comes from usually the tables of Bradley. So you cannot study Bradley all of it in one go. So studying tables from Bradley also, it's very difficult. So you need to know that which all tables are important in Bradley. So one of such tables is I'll show after this, after you answer this question. So read the question again and try to answer this. I'll put the polls. So try to answer this. So read the question. It's an except question. So first see the pathway. It is between globus pallidus, externa and subthalamic nucleus. So it is in the indirect pathway. So you need to study the table. So you know that the obvious answer would be what? The obvious answer, it is an inhibitory. So what we studied was that the connection between globus pallidus externa and subthalamic nucleus is definitely a red arrow. So definitely you know that it is painted in red. It's a red arrow. So it is GABA is definitely there. Your question is actually an except question. All of the following are neurotransmitters in the circuitry except. So it's much more complicated one than you think. And so the answer is actually there in a table in Bradley. That's why I wanted you to just read. So this is actually what we are talking is actually this pathway in the indirect one, externa to subthalamic nucleus. So here, what we see is actually this is a table in Bradley. You may think that it's very confusing and all. It's all we have, what we have studied in this this circuitry is just written. But apart from that, just extra points, what they have written is actually this one. That is a subthalamic nucleus, GPE to STN. Extra neurotransmitter which has been written is actually dynorphin, substance P, and GABA. And the others would be actually enkephalin. The others here, just you can concentrate here. So some points, you just go through it. Usually some extra questions could come from this table. Just read this. If you are comfortable, if you are well versed with the circuitry or the flowchart which we have studied regarding these pathways, you will be able to answer more than 95% of the questions. 5% extra, you can get it from the table. So next question, through which one of the striatal nucleus does the basal ganglia circuitry involving the associative functioning, involving the cognition pass through? So we have studied last time that we have simplified a difficult table in the Bradley, which was concerning 5 loops in the basal ganglia circuitry. There are 5 loops in the basal ganglia circuitry, and which passes through 3 areas in the basal ganglia nuclei. So 5 basal ganglia circuitry loops, which passes through 3 areas in the basal ganglia to produce various functions. One would be cognition, one would be movement, and one would be emotion. And so that was the table which we discussed last time. So this is just a revision question. If you had remembered the last class, you would have answered the question correctly. So let's see what the answer is. So last time we had, so this is between this is about a cognition, the cognitive pathway. So what we had studied is actually the functionality or the functional areas. So the 5 loops were motor, oculomotor, dorsolateral prefrontal, orbitofrontal, and the limbic loops. And it was associated with motor, cognitive, and emotional, which was going through the caudate, putamen, and ventral striatum. And this was the pathway. So the table we were discussing was the cognitive function passes through the dorsal caudate nucleus. So the associative division passes through the dorsal caudate, and it is concerned with cognition. So what is concerned with movement is actually going through the putamen, and emotion is actually going through the ventral striatum, which is actually the limbic division. So this is just a table in Bradley. Just go through it. So this is one of the questions. So now last time we knew that the most of the questions in Parkinson's disease are centered around the drugs in Parkinsonism and genetics of PD. So this question try to answer. The genes product dardarin is associated with which of the following Parkinson's? Is it 1, 2, 3, or 5? So question number 5. It's a direct question. Okay. Okay, let's see. So these were the tables in Harrison, which you need to know of. Last time we were discussing regarding Kufor-Rakeb disease, SNCA mutation. LRRK2 is the most common genetic Parkinsonism, which occurs in less than 40 years of age. And PARK2 mutation. So gene responsible for PARK8 is LRRK2. And this is associated with a gene product that is dardarin. Dardarin means actually tremor. And so dardarin is associated with which mutation? Actually, it is associated with PARK8 mutation. So next question, it's actually a clinical question. Try to answer this question. You read the question and answer. So it is regarding a 33-year-old welder who presented with history of cognitive slowing. That is all regarding Parkinsonism. So welder with Parkinsonism and all the features of Parkinsonism, and with an atypical gait, which we call as coke walk gait. So he walks like a coke, that is with a toe hyperextension. And so what do you think? So actually all of them have answered it correctly. So it is actually a repeat question. So the answer is actually manganese. So there is more to this. So this is otherwise called, it could be called as manganism, that is accumulation of manganese within the body, within the brain, especially in the basal ganglia. So it is usually found in welders, miners, in mining and industrial workers, also in patients with chronic liver disease, and also in patients who are on total parenteral nutrition. So these patients will be having Parkinsonism features because the accumulation is occurring in the basal ganglia, and maximum accumulation occurs in the globus pallidus. So this is actually a T1 weighted image. So T1 weighted image is usually, as we last class we discussed, T2 weighted image, water white into World War II. So CSF would be white. So this is actually black image. CSF is black. So this is a T1 weighted image, and gray matter is gray, white matter is white. And here the basal ganglia shows hyperintensity. The other conditions where the basal ganglia could be hyperintense would be due to liver failure, blood products, fat, TPN, manganese toxicity, etc. And other causes of early onset Parkinsonism syndromes could be, in young patients, could be due to drugs. Always think of Wilson's disease, Huntington's disease, neuroacanthocytosis. You know that neuroacanthocytosis, we have to look for peripheral smear for neuroacanthocytes. We last class discussed regarding DYT5, DOPA responsive GCDH deficiency. Then Halloween's disease, which is NBIA. Then all these drugs, that is toxins, that is manganese, mercury, methanol, carbon disulfide. These can cause early onset drug-induced or atypical Parkinsonism in young patients. So when before the era of L-DOPA, that is levodopa, this Parkinsonism was staged based on Horn and Yahr staging. So now it has modified into modified Horn and Yahr staging. So what do you think is the number of classification or stages in the Horn and Yahr stage? So what are the number of stages? So worst stages would be how much? How much actually? Number of stages. Worst stage would be how much? So you should be aware of that there is staging of Parkinsonism based on the laterality, unilateral, bilateral, bedridden, and all. This was a previous staging. Before the L-DOPA treatment was instituted itself, this staging was there. After L-DOPA was started, the stage was modified into modified Horn and Yahr staging. Now we use the MDS, Movement Disorder Society, UPDRS scoring system for staging. So most of them have, I think, maximum 15 have answered. All of them have equal spread of answers, equal distribution of answers. So the answer is actually 5. So this was the previous staging, where if there is only unilateral involvement without any functional difficulty, it was staged as 1. When fully confined to bed, it was staged as 5. Now it has modified into 1 and further divided as 1.5 up till 5. Again, it's same as 5 only. Now we have another one, is that the MDS UPDRS scoring. And we have to know that there are 4 parts of this scoring. This is a big scoring system. And part 1 deals with the non-motor aspects of daily living. Part 2, motor aspects. Part 3 is the motor examination. And part 4 is the motor complication. That is the dyskinesias, functional deficit, off period, on period, etc. So this is a very important classification. This is what we follow in our clinical practice, the MDS UPDRS scoring system for Parkinsonism. You have to be aware of all this. Questions could come like, we are giving importance to the non-motor aspects of Parkinson's these days, as we have seen, apart from the cardinal manifestations of TRAP. So as we have seen, most of the questions in Parkinson's, coming from Parkinson's, could be hovering around the drugs in Parkinson's disease. Last time we had touched upon or discussed regarding the pathogenesis, means the mechanism of action of most of the drugs. Now, a step ahead, we'll see what are the studies which you have to know about the drugs in studies on the drugs in Parkinson's disease. So after the 1817 article monograph of or the writing by James Parkinson on shaking palsy, much have changed regarding Parkinson's disease. So try to answer this question. Only if you have read, you would be able to answer. But this is pretty simple, because this is how you have to answer. Even if you know, if you got an idea of, I think this poll, I think I had answered it wrongly. Okay, leave it. So this answer is actually L-DOPA. So L-DOPA study was dealing with, which one of the following studies looked into effectiveness of selegiline in Parkinson's disease? So L-DOPA study, as we know, you can rule out L-DOPA study. So L-DOPA study was dealing with actually early Parkinson's disease with early Parkinson's, whether you start with levodopa or you wait for some time and then start with levodopa. And the other options were tempo, adagio. These are associated with selegiline. And Datatop is the study. Yes, you are answering correctly. And the last option, I put the 2 options similarly. That's why I just stopped the poll. The Datatop study is the one which was dealing with the selegiline, which is a MAO-B inhibitor. And the one more molecule which it was looking into was tocopherol. So it was the Datatop study was started in 1993, and an extended version of Datatop was again done in 2002. So Datatop was done in 1993, again in 2002. So 2 drugs which was studied was, one was selegiline and one was vitamin E, that is tocopherol. So these all could be questions. 2 other studies you keep in your mind, that is Seledo and PD-Med. Seledo was in 1999 and PD-Med in 2020, just for the sake of knowledge. So Datatop is the most commonly asked and repeatedly asked study, and it's repeatedly asked MCQ in exams regarding selegiline. And rest of the studies I'll just discuss. So again, this try to answer this question. Question number 9. So we discussed regarding the studies. So Datatop was dealing with selegiline. And last question itself, we had discussed that rasagiline was dealing with tempo and adagio. So what are the studies on rasagiline? So MAO-B inhibitors are widely studied because this is the only drug which is actually a disease-modifying drug. One of the very good drug in Parkinson's disease, even though it is a levodopa, it doesn't have a disease-modifying action. Only disease-modifying action, which is acting on the mitochondrial enzymes, mitochondria, is actually MAO-B. So MAO-B only has got a disease-modifying action on the Parkinson's disease. So this is widely studied. Selegiline, you had seen the studies Datatop, and here rasagiline. Yes, most of them have answered correctly. Tempo, adagio, and presto are dealing with rasagiline, and stride PD is not dealing with rasagiline. Okay. So studies on rasagiline, just keep in your mind or see this video again just before your exam. These are the studies on rasagiline. And always remember these stairs. These are stairs climb. These are stairs to climb. So first step and stride PD. These are the two studies dealing with COMT inhibitors. That is, what are the COMT inhibitors? Name them. Tolcapone, entocapone, and one more is there, opicapone. So remember the steps. First step and stride PD. Steps, stride. You find the step and stride over it. That is regarding COMT inhibitors. So that was regarding COMT inhibitors and MAO inhibitor study. So this is the question regarding a newer COMT inhibitor. That is regarding, this is question number 10. Okay, question number 10. I'm launching the poll. So this is a much talked about drug, that is opicapone. Which one of the following statement regarding COMT inhibitors is true? So what do you think is true regarding opicapone? So last class, you must have studied regarding the COMT inhibitors, their side effects. Tolcapone, the side effect was actually hepatotoxicity and discoloration of urine. Okay. Yes. So the answer is that yes, opicapone was the drug which was approved in 2020. That is the correct answer. And it can be used as a it is used as an OD dosage. That is one more advantage. But the others is used as either a BD or a thrice daily usage. And tolcapone, as you know, is actually not only a peripherally acting drug, it is also centrally acting. So that is one more advantage of tolcapone over entocapone. And entocapone definitely causes urinary discoloration. It causes a bright orange urine. So as we have seen here, this is the periphery and this is the central. So we have seen here the entocapone and tolcapone acts in the periphery, but tolcapone also acts in the central region. So this is the central region and this is the periphery. So tolcapone has also a central action apart from the peripheral action. And so tolcapone, as you know, it has got hepatotoxicity, so should be used in caution. It has got both central and peripheral action. It has got a dark orange brown urine. Entocapone has got dark orange brown urine. So which one of the following calcium channel blocker is being used in studies to check usefulness in Parkinson's disease? So this question I had put just because of the reason that I got a query from one of the students that in Harrison there is a word that calcium channel blockers are actually protective in Parkinson's disease, and another portion of the Harrison just shows that it is actually harm, or it is actually one of the risk factors or one of the detrimental factors or risk factors of Parkinson's disease is actually the use of calcium channel blockers. That is why I put this question so that the confusion is solved. So this controversial area in Harrison can be solved with this question. So which one of the following calcium channel blockers? So you have to know that flunarizine and cinnarizine are calcium channel blockers, and you all definitely know that amlodipine is a calcium channel blocker. Isradipine you are not sure of. So so definitely you might want to answer as isradipine. Yes. So actually drugs causing Parkinsonism, actually these flunarizine and cinnarizine, anti-vertigo agents, etc., are actually causing Parkinsonism, and antipsychotic agents causing Parkinsonism. So you need to know about one thing. Actually, flunarizine and cinnarizine are notorious to cause Parkinsonism, that is drug-induced Parkinsonism, which is a calcium channel blocker, which acts on L and T-type calcium channels. And the thing was that recently in 2014, what happened was this isradipine, which is an antihypertensive drug, which was FDA approved for hypertension, was thought to be useful in case of Parkinson's disease, and hence a steady PD3 study was instituted to check into the look into the usefulness of isradipine. But this study failed miserably because of its side effect. The main side effect of this drug was actually edema and severe dizziness, and hence they have come up. NEJM article has come up that never use this drug in case of Parkinson's disease, and this study is useless. So, and but still it's controversial. So in a nutshell, calcium channel blockers are not effective in case of Parkinson's disease, and more commonly used drug like flunarizine and cinnarizine are notorious to cause drug-induced Parkinsonism. So that is actually one controversy, I think, is kind of solved with this steady PD3 study. So all talked about Parkinson's disease. The latest in the pipeline is actually deep brain stimulation. Deep brain stimulation has been useful in many diseases like dystonias, tremors, even epilepsy. It has been tried. It has been also tried in depression, even Tourette syndrome. So many diseases it has been tried. So deep brain stimulation does seen in Parkinson's disease has shown good results, especially in deep brain stimulation in specific nuclei. That is, we have seen the basal ganglia circuitry. So we stimulate certain nuclei. We either increase the dopaminergic secretion or stimulate the neurotransmitter release from the certain nuclei, or decrease the stimulation with the help of deep brain stimulation targets. So my question here is actually, which one of the following DBS targets release only the tremor symptoms in PD patients? We know that the symptoms in PD is actually divided into TRAP, that is tremor, rigidity, akinesia, and postural instability. So which one of the following DBS targets? So we have subthalamic nucleus. We have seen the circuitry as such. So substantia nigra could be even a target. So nucleus and accumbens, as we know, is actually kind of related with cingulate circuit. So it is associated with emotion. So you can roll out that answer and try to answer the question. Which one among the following targets release only the tremor symptoms in PD? So tremor, even essential tremor also could be treated with a deep brain stimulation. So this question could be modified. Which one of the following DBS targets relieves tremor symptoms in essential tremor? Then also, if same options are given, you should have an answer to that. Okay, most of them have answered it as subthalamic nucleus. So the answer here is thalamus. So Wim nucleus of thalamus. So you have to know that DBS could be used in all these kinds of diseases. Basically in PD, essential tremor, dystonias, etc. Epilepsy, it has been tried. Others are actually not used at that common, just study based. So what is this DBS? DBS, as we have seen, it's actually, we are stimulating or manipulating the release of neurotransmitter from a certain area of the brain so that the functionality is maintained. So what went wrong in case of Parkinsonism we had discussed last time? So what went wrong in the direct pathway? There is actually inhibition of thalamus. So we had inhibition of thalamus in case of direct pathway. Here we had seen inhibition, so decreased. And there is stimulation of indirect pathway. So more negative impact on the thalamus here. So again, there is decreased output from the thalamus. So this is one of the nuclei which has more hyperstimulated here. So these two are the areas which are severely affected in case of a Parkinson's disease. So if you have to decrease the symptoms in case of a Parkinson's disease, that is the trap symptoms in Parkinson's disease, we have to put an electrode, that is DBS electrode here, deep brain stimulation here. And as we know, in case of tremor, if you want to decrease tremor symptoms, it's a hyperkinetic movement disorder. Tremor is actually increased activity. So in case of tremor symptoms, we can put electrode here. So three areas usually where we put DBS electrodes are actually subthalamic nucleus, most common, followed by GPI, globus pallidus interna, then thalamus. And thalamus, if you put a deep brain stimulation electrode, it mainly elevates tremor symptoms alone, not the other symptoms of rigidity and bradykinesia. So that is regarding deep brain stimulation. So which one of the following is not the mechanism of action of safinamide? So that was regarding deep brain stimulation. You just read through about deep brain stimulation. It is a upcoming field, so more questions could come from it. So safinamide is also a newer drug. Studies by Dr. Rupam sir has been done from Hyderabad. One of the studies from India only. So that's a proud thing for us. So safinamide drug is actually a MAO-B inhibitor. That all we know, that last time we had discussed in the last class regarding MAO-B inhibition of safinamide. So which one of the following is not a mechanism? It is not a single, it has got multiple mechanisms rather than just a MAO-B inhibition. So what is the other mechanism of, because of this multiple mechanism, it has got a good effect. So in a patient who is on levodopa and is having a side effect of levodopa, that is dyskinesia, if you add this drug, it is very useful. And we add this drug at a dose of 50 milligram OD for 2 weeks and then up titrate this drug, safinamide. So which one of the following is not the action? So yes, most of them have answered it correctly. Most of them has read about this drug. So it's a highly selective and reversible MAO-B inhibitor, unlike the others. So what is wrong with this selectivity and reversibility is that if there is some MAO-A action, that is MAO-A action, what happens is that if MAO-A action is there, then there is chance of cheese reaction. And the MAO-A is actually inhibition is needed only for, as we know, is needed only for psychiatry and not for our movement part. So selective MAO-B inhibition is necessary for Parkinsonism. And what happens is, if there is, if it occurs, there is increase in the dopamine which is needed for our Parkinson's patients. And this results in what is called blockage of sodium and calcium. And thus, as we can see, this safinamide causes blockage of sodium and calcium channels within the glutamine. Yeah, you can see glutamine, and thus there is inhibition of glutamine rather than GABA. So sodium channel blockade, calcium channel blockade, and glutamine in turn is blocked. So that is regarding safinamide, which is a newer drug in Parkinson's disease. So that was regarding. So this is an MRI. So we discussed last class regarding a T2 weighted image. This class regarding a T1 weighted image where we had a hyperintensity in the basal ganglia. And this is actually a SW image or a subtraction weighted image. So this is actually a subtraction weighted image where we look for either bleed or calcification. So SW image is shown here, and we have this region. This is actually midbrain region. Sorry, midbrain region. We have, you can see this midbrain here. If you see, this is the midbrain here. Okay, I think you made out the midbrain here. So What is the sign shown here? What is the sign shown here? This is question number 14, I guess. Sign discussed above. So I have launched the poll. Sign discussed above is seen in. So again, the question, you haven't read the question but started answering. Okay. The sign discussed above is seen in. So we have a representation of a swallow. That is actually a swallow with her tail there. The sign discussed above is seen in. Yes. Okay. This is actually a swallow tail sign. Swallow. You can see that in this question we had seen that there is a swallow with the tail shown there. This is a swallow tail sign. This is actually a normal finding, which is seen in normal individuals. And this has been found to be a new finding, earliest finding in case of, this is actually a normal finding. And when this is lost, this has been a sensitive finding in case of idiopathic Parkinson's disease. So I'll just discuss about it more. Just one more thing I wanted to, we saw a midbrain there. I just wanted you to answer this question. Which among the following is the most abnormal representation of the midbrain, which is a bad midbrain among the following? If this is an SW image as shown below, which is the worst midbrain shown here? Just try to answer. This is a fun question. We'll take this, we'll make it a bit fun. Okay, everyone has known that middle two are not the answers. Okay, either it could be the first one or the last one. Definitely. Just that part is okay, fine. So just wanted to tell you that actually swallowtail is actually a normal finding. So blackened thing is actually what is normal, and in between this black we have a hyperintensity here. This is actually normal finding. This is swallowtail sign. In between the swallow we get a hyperintensity, and if the swallowtail is lost, completely blackened out, that is abnormal, and that is found to be a newer sensitive finding in case of Parkinson's disease. So this is a new thing which has been come up. So as you can see that this is due to something, I'll tell you. So in case of Parkinson's disease, as you know that it starts unilaterally. So this is actually the normal side. So if it is actually one-sided Parkinson's disease, you are prone to get MRI finding, that is SW image. You are prone to get absence of swallowtail in one side. So, and if it's case of an advanced Parkinson's disease, you get bilateral absence of swallowtail sign. So why this occurs is because that hyperintensity here, this white thing is due to some material called nigrosome 1, which contains less of iron, and it's less of iron is there. And in case of Parkinson's disease, less of iron and more of dopaminergic neurons. And when there is depletion of dopamine of this special area, there is accumulation of iron here, and that area, iron in this SWMH, iron is actually a byproduct. That is why bleed and all get blackened in case of an SWMH. So SWMH, I made you aware of. So this is actually regarding nigrosome, which has a highest concentration of dopaminergic neurons in the this area, that whitened area you see. And in case of PD, there is depletion of this nigrosome, and then hence there is loss of swallowtail sign. So just remember that absence of swallowtail sign is seen in Parkinson's disease, and it was found to be a newer imaging modality of high sensitivity for detecting early Parkinsonism, and it is helpful in differentiating it from essential tremor and other mimics of Parkinson's disease. And normal swallowtail sign is found in normal individuals. So try to see this video. The first video is actually a gait video where the patient is walking with a white-based gait. So, and this is actually a patient with having difficulty in having dysadiacokinase. So she is unable to do a rapid alternating movement properly. and still
കൈ ഇങ്ങനെ പിടിച്ച്
3 to 4 months
നെറ്റിയിൽ തൊടു,
are
നെറ്റിയിൽ
illness,
തൊടു, എൻ്റെ വിരൽ തൊടു,
and she has been
എൻ്റെ വിരൽ
having
തൊടു, നെറ്റിയിൽ തൊടു,
severe
എൻ്റെ
stridor
വിരൽ തൊടു,
for past 2 months. Severe
നെറ്റിയിൽ തൊടു, എൻ്റെ വിരൽ തൊടു,
stridor is there. Yes, my
നെറ്റിയിൽ വിരലിൽ,
yes,
മറ്റേ കേസ് ചെയ്ത്
intentional tremor
നെറ്റിയിൽ തൊടു, എൻ്റെ വിരൽ തൊടു, നെറ്റിയിൽ തൊടു,
that you can
വിരൽ
see.
തൊടു, നെറ്റിയിൽ
She has
തൊടു,
got
വിരൽ
fast
തൊടു.
pointing. Yes. So she has got Parkinsonian features, mild Parkinsonian features. She has got postural hypotension, sweating episodes. Her extremities are cold and clammy. She has got, as you had seen, these findings. Gait I couldn't show, and she has got stridor. What do
ബ്രോഡ്
you
ബേസ്ഡ് ആണ്,
think?
എനിക്ക് ബ്രോഡ് ബേസ്ഡ്.
Yeah, gait is sorry. I think gait is actually kind of cerebral. So you got the answer right now. I think uh, there is no need to go for the polls. Question number 16. So this is actually a Parkinson plus syndrome. Everyone should answer. It's a straightforward question. No. So more of cerebellar signs. We had elicited the cerebellar signs more rather than Parkinsonian features. Okay. This patient was in the ward last week. Since she had a rapid onset of symptoms, we worked up for other features of other causes of rapid onset autonomic dysfunction with cerebellar findings. So this is actually a MSAC. You know the other findings in MSAC, where in MRI you have the hot cross bun sign and all. So we have a constellation of findings of Parkinsonism. There will be cerebellar findings and autonomic dysfunction, which could be either you in the form of urinary symptoms. In males, you have erectile dysfunction, and as you have, because of their autonomic dysfunction, there will be cold clammy extremities, and there will be a orthostatic hypotension. We have studied the value would be 30/15, and as you know, the stridor would be there. This patient had severe stridor, so that is regarding MSAC. So this is a question taken from Bradley. Wilhelm Lynch disease is associated with which of the following diseases? So try to answer this question so that you never forget about this disease. Yes, most of them have thought that this is a class of Parkinson's disease. So I'll answer the option as Parkinson's. Yes, you are right in one way, but you should have read the options. Yes, it's actually all the boy. I just wanted you to remember the question. I didn't want to check your whether you have read or not. I just wanted you to remember this disease. It's difficult to remember. It's just FTD 17, which was previously called as Wilhelm Lynch disease. It's there in Bradley. Just I wanted to make your notice, take your notice to this question. So it's actually FTDP 17. It's commonly coming. Question FTDP 17 is commonly asked. So this is actually there. So this could be also asked. So some drugs in case of orthostatic hypotension, the norepinephrine precursor doxidopa approved for by FDA in PD is actually useful in which of the following diseases? Following symptoms is useful in relieving which of the following symptoms? I think I have already given the answer. So yes, dyskinesia. I would some people have answering as a dyskinesia. I would give amantadine. Okay, fine. So actually, the answer is orthostatic hypotension. So orthostatic hypotension in case of Parkinson's or even Parkinson's disease patient is prone to have orthostatic hypotension. It's not that a patient presenting with Parkinson's disease having orthostatic hypotension should be branded as a MSA or MSAP or MSAC. It's that if so, orthostatic hypertension can be managed conservatively with salt supplementation, or you can give a fludrocortisone, midodrine, or droxidopa. These are the drugs which are used for treating orthostatic hypotension in case of Parkinson's disease. And which among the following drugs is not useful in treating the wearing off effect. So what we are talking is actually regarding the drug induced, that is drug side effects of Parkinson's disease. So which of the following is not useful in the treatment of wearing off effect in Parkinson's disease? It's pretty simple questions, straightforward, nothing to worry about. So don't get confused. Wearing off effect means actually the drugs action gets over and the patient gets stuck again. That is, extrapyramidal activities come back earlier because of kind of tolerance to the drug. So definitely the answer should be baclofen. So what is levodopa? Most studies, that is actually levodopa, carbidopa infusion gel. That is combination of that is actually levodopa. We have dealt with COMT inhibitors and MAO inhibitors, which increase the carbidopa, that is levodopa within the neural junction. And baclofen is used to treat dystonia rather than the wearing off effect. So this is a table in Bradley, which deals with the fluctuations in Parkinson's disease, drug-related fluctuations. It could be either wearing off, dyskinesias, morning dyskinesias, and on-off fluctuations. So baclofen and Botox injections, etc., are useful in case of morning dyskinesia, also dystonias. And if you chew or crush the first dose and even drink it with Pepsi and all, that also will relieve morning dystonias. Others, any drug can be used. Even amantadine can be used for wearing off as well as dyskinesia. We have seen in the last class that one of the MCQs commonly asked is drug-induced dyskinesia. Most commonly used drug is amantadine. So this is one of the tables in Bradley. So this is the levodopa LCIG gel, which can be either given by NG or PEG, nasogastric or PEG. So as you know, more studies are going on regarding stem cell therapy, which is not shown any success till now regarding Parkinson's disease. Then regarding many new drugs and gene therapy in case of Parkinson's disease. And so that is the importance of this question. So as we have seen, genetics have come up in Parkinson's disease. We have come to know that one of the diseases, that is Gaucher's disease, which is which has an association with Parkinson's disease. So Gaucher's disease, how it is associated with Parkinson's disease, try to read, and if you get it wrong also no problem, but just to know that there is an association between GBA and SNCA gene. GBA is associated with Gaucher's disease. I think the poll has been launched. It's not coming. It's okay. So there is a chance that Gaucher's disease commonly shows signs of Parkinson's. And the wrong answer in this is actually encodes the enzyme glucocerebrosidase. And what is the drug of choice in psychosis in case of Parkinson's disease? What is the drug of choice? Can you see? Can you take the poll? Yes, very good. Please try to answer. What is the drug of choice for psychosis in Parkinson's disease? Pretty straightforward question. So as we know, this antipsychotics acts through dopamine receptors. They act by blocking the dopamine receptors. And what happens in PD is that if you block the dopamine receptors, the motor symptoms will aggravate. So what happens is if you give a Parkinson's disease having a psychosis, if you give this antipsychotics, they are prone to increase, their motor symptoms are prone to increase. So what will you do in such a case? So that is why one of the antipsychotics which has been recently approved is actually pimavanserin. The haloperidol, as you know, is actually a typical antipsychotic, which is more D2 receptor. And the rest of them are all acting through dopamine. And pimavanserin is actually a serotonin selective. It is actually SSIA, that is serotonin inverse agonist. So SSIA, pimavanserin. So that is one thing. So I think with this, we have completed the advanced part of Parkinsonism or the hypokinetic movement disorder. We had dealt with dementia with Lewy body and CBGD while dealing with the dementia part of this neurophilia series module. That's why I didn't touch upon this. And I'll repeat to you that this is not a capsule form of what we need to learn regarding a complete part of Harrison or complete part of Bradley. It's to make you read the parts of Bradley and Harrison, where the parts, I'm telling you the parts you need to emphasize, so that you don't miss while reading for the exams, and to make you read uh, both the books so that you are prepared by the time you read, you write the exams in June and maybe by June, July month. So I think we have covered 6 modules. Hope you have gained from these and you have started studying. If not, it's February. It's high time you start studying. So I think we'll wind up this session. I think there will be no class next week. After that, we'll take the neuromuscular junction 1 class. And after that, hyperkinetic movement disorder by Dr. Ashish. And then March will be kept for pediatric neurology part. So there will be exam on Parkinson's, that is hypokinetic movement disorders, this Sunday. So everyone has to write this exam. I'll keep it in the group. So thank you. Thank you.